grand rounds. We are very pleased to have Swapna Deo, who will be giving today's lecture. She is a graduate from Mumbai, St. G.S. Medical College, graduated with distinction, winning multiple awards, and then came to Cincinnati to do her internal medicine residency, and came to Louisville to do her endocrinology fellowship. She was an excellent fellow. She has many publications and presentations during her fellowship and has done extremely well in her practice at Norton's. She's also currently assistant clinical professor in our division, and she staffs some of her endocrinology clinics with our fellows and is highly regarded for her teaching and expertise. And we are very happy to have her talk today about osteoporosis in men. Thank you.
Thank you, Dr. Moshe, for the kind introduction. Good afternoon, everybody in person and virtually. So I'm doing this for the first time, but hopefully it'll be all seamless.
I believe you muted your mic accidentally. We can't hear you.
Okay, I think it got muted again, so sorry about that. So let me restart. First of all, I would like to thank Dr. Moshe for the kind introduction, and I'd like to welcome you all on this day, this afternoon, both in person and virtually, for being here for my talk. Every year, choosing my grand round topic, like I was saying, is a very interesting exercise for me because I like to pick a topic that was challenging for me in my clinical practice, patients that I saw, and that I had probably a need to go back and do some reading. So the topic today is osteoporosis in men. Hopefully it'll be just as interesting to you and you'll learn something. Breaking trends. And I hope you get that. Oh, okay. All right. Hopefully you won't see all of us on that screen now. This would have been an excellent topic. It keeps going there. Hang on. Okay. All right. I would have loved to have the audience polling on this topic, but unfortunately we don't have it. So we'll just go with, yourself polling, and then you're more than welcome to put it on your evaluations, particularly audience who fits into this category, so men more than 50, so 50 to 69, and men more than 70 years of age, if they would change anything for their own personal health, and then in general, just as clinicians, what we would do differently. So the main objectives is know the incidence of osteoporosis in men, learn the differential diagnosis of the causes of male osteoporosis, and diagnostic tests to order. And then lastly, we'll discuss some treatment options for osteoporosis in men. I have a lot of slides. If I'm going too fast, let me know, but I do want to get eventually to my patients at the end of the talk so that we can do a little bit of brain exercises there. So we'll get to know some breaking trends and break our current trends of screening and treatment. So what is the definition of osteoporosis? Osteoporosis is a silent disorder which is characterized by low bone mass, microarchitectural disruption, and increased skeletal fragility. The clinical diagnosis of osteoporosis may be made just by the presence of a fragility fracture, particularly at the spine, hip, wrist, humerus, or pelvis. And fragility fracture is a fall from standing height or any minimal trauma. In the absence of fragility fracture, though, BMD by DEXA is the standard test in the US to diagnose osteoporosis in men more than 50 years, according to the WHO. So by the WHO definition, a bone marrow density 2.5 or more standard deviations below the normal young mean classifies as osteoporosis. The WHO and the ISCD concluded that fracture risk in women and men occurs at about the same absolute BMD, and hence they use a white female normative database for men as well as women. but this has differed overall. The ISCD definition is subcategorized into men more than equal to 50 years, where osteoporosis is defined by value of BMD minus 2.5 below SD, below the young, healthy female mean, whereas in men less than 50 years, they do have some recommendations as well, where they say that BMD alone should not be used to diagnose osteoporosis. Additionally, we use the Z-scores, where Z-score less than equal to minus 2, when there's a history of fragility fracture, or in addition to risk factors such as glucocorticoid therapy, hypogonadism, or hyperparathyroidism concurrently, may be classified as osteoporosis. Otherwise, it's just called low bone density. In 2013, the National Bone Health Alliance advocated the use of FRAX calculation, which is the fracture risk calculator, of a 10-year hip fracture risk of more than 3% or any major osteoporotic fracture of more than 20% to define osteoporosis, but that's not used universally. So just to look at some fracture rates in men and women, this is a great graphical representation of the fracture occurrence per age. As you can see in females, the incidence of fractures increases right around menopause, which is right about 44 years of age. In men, you do see a peak here, and that's from traumatic fractures in younger kids and even young, healthy males. But then you see another steep increase, mostly around age 74. So just a little bit on the pathophysiology. The peak spine bone mineral density measured by DEXA is usually achieved by age 18 years in men. The BMD of the hip, though, is reached several years later. The BMD decline in men is more gradual, but it may begin as early as 30 to 40 years of age and occurs at a steady decline of 0.5 to 1% yearly. Microscopically, it differs from that in women in the sense that the trabeculae become thinner in men, whereas in women, the trabeculae actually lose their connectivity. Both estrogen and testosterone play a role in the skeletal accrual, and lack thereof, which can be seen in certain individuals where the testosterone levels are normal, but inactivating mutations of aromatase gene or estrogen receptor genes may still cause a low BMD because of low estradiol levels. So both estradiol and testosterone levels are important in BMD accrual and maintenance in men. Now, just some numbers. 2 million men over the age of 65 years in the United States have osteoporosis, and another 12 million men are at risk. Worldwide, almost 40%, nearly half, of annual osteoporotic fractures occur in men. By the age of 85 years, over a third of men will have a femoral neck T-score at or below minus 2.5, and by 90, 1 of every 6 men will have a hip fracture. Overall, the lifetime fracture risk for men aged 50 or older is about 13 to 30%. The vertebral or hip fracture prevalence in older men is about a third that in women, and the Achilles or wrist fracture is 1/6 that's common. So, yes, the osteoporotic fractures and incidence is high. What else does it mean? Well, men with high fractures have actually a 2 to 3 times higher mortality rate than women. The highest rates of osteoporotic fractures in the world are in Northern Europe and North America, and the lowest rates are in Blacks, Asians, and certain parts of South America. Overall, the impact of osteopenia was more evident in this Rotterdam study when the data showed that after age 55, osteopenic men are more likely to sustain a vertebral fracture compared with men with osteoporosis. And why is that? There's simply a lot more men by the definition of osteopenia in that age group. Just some numbers to show that mortality ratios overall at all sites, proximal femur, vertebral, and other major fractures, are higher in men versus women. In spite of so much data, men continue to be underdiagnosed and undertreated. This study was done, it's one of the recent issues of Endocrine Practice, November 2020, where they looked at screening patterns and they interviewed different specialists and asked them about the likelihood of screening, and there were more categories than this A and B, but majorly these two, where a 74-year-old man with no significant past medical history versus a 65-year-old postmenopausal woman, who would they screen? As you can see, the B, which is a 65-year-old postmenopausal woman, they almost always or frequently get screened, versus the men, 70 and above or 74-year-old, who would rarely to never get screened. Just a few likely reasons why physicians would screen. Also, it was evident from the study that endocrinologists are more likely to screen than other physicians. But chronic steroid use, previous non-traumatic fracture, androgen deprivation therapy, or ADT as it's abbreviated in most of the talk, and primary hyperparathyroidism along with hypogonadism were some of the top causes. And does go down, as you can see overall. So just to know a little bit about the screening trends, in a single institution study of 342 men aged 70 to 75 years seen by a primary care physician, only 18.4% underwent a bone density scan. In another study, men aged 70 years and older, just 11.3% were screened, and none more than 90 years were screened. Also, men are even less than women to receive the anti-resorptive therapy after a hip fracture. Just a tenth, 4.5% versus 49.5%. In this particular study, they studied the men 6 months after after a fracture with age 65 to 79 and 80 to 89. And the likelihood of DEXA scan, this is, let's see, I cannot read these numbers, but okay, let's go down below here. Only 7% were treated with an anti-resorptive therapy versus women, which was not that much higher either. And again, same thing, men and DEXA and treatment varied for these age groups. So why is it that we can't test enough for men? For one, I think it's mostly thought of as a women issue. There's also a lack of consensus regarding the BMD testing in men. The U.S. Preventive Task Force found insufficient evidence to make recommendations for screening older men. So they basically say you don't need to. However, a lot of other societies, including the NOF, the ISCD, Endocrine Society, the American College of Preventive Medicine, and ACP all recommend BMD testing for men older than 70 years. And then the Canadian Society recommends more than 65 years. In addition, these societies also recommend testing in men and women 50 years and older with any clinical risk of fracture. And the ACP has some similar recommendations. So according to the Endocrine Society, who should be tested? They recommend that age is a sufficient factor, and men aged 70 years and above should be tested. For men between 50 to 69 years of age, they should probably undergo testing if they have a history of fracture after age 50, if they have hypogonadism, delayed puberty, hyperparathyroidism, hyperthyroidism, chronic conditions such as COPD or other conditions that need steroid therapy, GnRH agonist therapy, and lifestyle, poor lifestyle choices such as alcohol use, smoking, or additional secondary osteoporosis. This is a very comprehensive list. I'm not going to go through all of it, but that would probably necessitate screening of men between 50 to 70 years with osteoporosis if they have an additional secondary cause, which is listed in here. But overall, hypogonadism and hypercalciuria are probably the most common causes. So this particular article has some more suggestions or guidelines about when men should be screened, and age more than 65, and one of these other factors, which includes anti-epileptic drugs, BMI less than 25, which was not in the other criteria, gastrectomy, and the other factors, which are other secondary factors which were mentioned earlier, should necessitate some kind of screening. Without these secondary factors, just age more than 80, chronic glucocorticoid use, high pre-screening FRAX score using BMI, or androgen deprivation therapy should also probably necessitate screening in men. Additional factors that was in this article by Adler et al. And then, again, ICD factors.
So NOF stays over 70, right?
Yes.
2010 they made the recommendation. So this is the ASBMR recommendation, or is it an individual paper by Adler, the one you just showed?
That is an individual paper.
Okay.
Yeah, it's not a society recommendation. But these are all these multiple factors, and let me go back if I can.
Okay.
You see, so as you can see in some of these, all these other non-specific factors which you wouldn't consider are also in there. Divorce, tall stature. This is actually a good one, where decreased motility or inability to do chair stands, Parkinson's, and then falls is actually a very important risk factor as well. You wouldn't break a bone mostly. You can have vertebral fractures without falls, but prevention of falls and the likelihood of falls is also a risk factor.
Chair stand is like assistance of sarcopenia.
Chair stand is just getting up from the chair without assistance.
It's like a sarcopenia.
Yeah, muscle weakness along with the fragility. So I didn't go over this, but I just wanted to put this in there just because every society has different kind of criteria for screening. So what tools should we use? So there is this guideline that has been put out by the Endocrine Society that gives you a pretty comprehensive overview of osteoporosis in men. And they recommend DEXA of spine and hip as the main tools. However, in individuals in whom osteoarthritis or degenerative disc disease of the spine may forbid the use of these sites, you can use the distal third of forearm, and also in certain conditions where the cortical bone is affected more, such as hyperparathyroidism, and ADT or androgen deprivation therapy patients who've had prostate cancer should also get a distal third of the forearm. Vertebral fracture assessment may be needed in some men with low bone mass who have suspected vertebral fractures. In this case, basically a good history and accurate measurement of height, which will show a decrease in height of about 5 centimeters or so, would be a good factor for suspicion. The ISCD, and this 6 centimeters is 5 to 6 in different articles. The ISCD recommends VFA for men over age 80 with osteopenia, or younger men with a height loss of more than 6 centimeters. And then men between 70 to 79 are also candidates for VFA if they have chronic conditions such as COPD, rheumatoid arthritis, or Crohn's disease. So easy said than done. I have tried ordering DEXA scans on my 70-year-old patients without much of other risk factors. So considering age as the only risk factor, I've almost always been denied. So third-party payers, including Medicare, vary in the DEXA coverage for men. Medicare will cover the initial DEXA only in men who have vertebral fractures, so they've already had an issue. Radiographic osteopenia, again, they're already showing signs of it. Hyperparathyroidism or an oral glucocorticoid therapy. And DEXA forearm may not be covered by Medicare. So then, is there something else that we can use without ordering DEXA? So FRAX alone as a tool for assessment was studied in this particular study. And what they found was FRAX alone without BMD provides the same prediction as FRAX with BMD. And the younger age is more indicative of being closer to the identical prediction. Of note, FRAX is used in UK with just BMI, where they use that to categorize them into low risk and high risk. And as far as I know from that one article I read, they may even treat them just based on the high risk without actually getting a DEXA. So what were the salient features of the study? FRAX and FRAX with BMD produced identical fracture risk predictions for 84% of the subjects included. The inclusion of BMD did not result in a different prediction for these 127 subjects. Of the 16% of the 24 subjects for whom the BMD inclusion resulted in a different FRAX recommendation, actually the treatment was recommended for only 2 subjects. And if anything, the FRAX without BMD recommended treatment for more subjects than those who were not identified with the FRAX and BMD calculation. So it overestimated the amount and not underestimated. And another retrospective study, of a large clinical cohort of almost 37,000 women and 3,000 men, they concluded that a FRAX designation of high risk of fractures usually concurrent or associated with a densitometric diagnosis of osteoporosis. There are different calculators, and just like the FRAX, this fracture risk calculator is also another tool for assessment. I know you can't read that, but I just wanted to put in a screenshot just to show you what it looks like. And in this validation of FRC or fracture risk calculators tool in this MROS study, which was a huge study that studied a lot of different parameters, it was concluded that the FRC risk calculator calibrates well with hip and major osteoporotic fractures observed among older men. Adding the BMD improved its efficacy a little bit, but just by itself too, it was fairly useful. Yeah, the GAR1 tool. So there's a lot of different tools, and I think FRAX is the most commonly used one. But right, but this one, the FRC also takes into account, there's a few different things that it takes into account that the FRAX doesn't, and one is the glucocorticoid. I don't know if you can strain to see the amount of glucocorticoid dosage, a spine fracture. So some of these parameters which are not considered, the vertebral basically are not considered in the FRAX, are present in the FRC.
So did they tell you what drives those? What are the primary things that are driving those numbers?
Which
there are so many factors there.
How they calculate it?
But they're all given the same weight, correct?
No, I don't think so, because I have used this just on mock patients, just like trying to put in one number and the other, and it does vary quite a bit. So I don't know what the algorithms are,
okay.
Or I may not have.
Whether saying that there's a family history or saying that I'm on glucocorticoid gives you a higher score?
It does.
Whether that is the main driving force, like because these patients, X number of them had one of these very high risk factors, which is why they were able to predict it more?
I think so. I can't tell you because I didn't go into how their algorithms work, but I'm sure there's information about them. It does say that it has compared it to just the FRAX, and at extremes of age, it does a little bit better because the FRAX. And I wasn't going to go over this chart here really, but this is the hip fracture. The gray bars are without the BMD, and the white bars are with the BMD. And if you can, let's see, in this hip fracture, as you get older, it probably doesn't matter as much. At 80 plus, you can see these 2 bars with or without the BMD measurement. And apparently, from what it says, the FRAX scores underestimate the fracture risk in the older population, so it's kind of helpful to have the FRC instead. So what are the causes of osteoporosis? There's primary causes and secondary causes. In general, secondary causes are a lot more common. Primary causes mainly not enough bone accrual. So the peak bone mass is not achieved, and it could be because of genetic predisposition, chronic illnesses as a child, medications, basically steroids or so, or antiepileptics that might negatively impact the bone density, idiopathic hypogonadotrophic hypogonadism. Delayed puberty, even after it's corrected, can still cause a lower starting bone mass, so they're more likely to have osteoporotic changes later. And just a normal decline with age, which occurs in men after the age of 40. The secondary causes are multifold, as you can see, and thorough history, physical exam usually will be able to differentiate one over the other. So patient's personal fracture, fall history, pubertal age, history of hypogonadism, chronic diseases, and their therapies, history of renal calculi, which would basically point towards hypercalciuria, history of parental fracture, including age of parental fracture. So if it's less than 80, it's almost as if it's how the cardiac risk factors are, lower age is considered to be more significant. Smoking history, alcohol use, medical illnesses, and medications. So history taking is just as important. Exam. I always make it a point for my new patients with osteoporosis or anything to do with BMD that my MAs actually check their heights, because I have initially, when I started, I found that the heights were just written from what the patient recalled, and they were 5'7" when they were 18 years old, and now they're 5'4", and nobody ever noticed. And a lot of these vertebral fractures, which cause height loss, might be missed. So current height versus maximum height, kyphosis, their frailty, their overall muscle strength, sarcopenia, like Dr. Krishnasamy mentioned, and then other causes, secondary causes, which might be pretty evident, hypogonadism signs, testicular exam, that's abnormal hyperthyroidism, or COPD would be just some basic. I'm not going into the detail of history and exam. I know most everybody will be very efficient at doing this. What should be the initial lab testing? So at the very least, to begin with, we all need to get calcium, phosphate, sorry about the GFR, creatinine with the estimated GFR, alkaline phosphatase, liver function, vitamin D, total testosterone should always be checked, and CBC, because you might have any indications of multiple myeloma or so. 24-hour urine calcium and creatinine and sodium should be tested for hypercalciuria. So this gives you a kind of a directed testing guideline for each condition that you might already have narrowed down and be suspecting after your initial physical exam and labs. So for hypogonadism, of course, you want to get your testosterone, but also try to get the LH, FSH, and prolactin. I had mentioned about estradiol in the very beginning, that estradiol is important along with testosterone. However, there's no guidelines and no algorithms in place to do anything in particular with the estradiol level, so they're not actually in this recommendation diagnostic testing. But testosterone levels less than 200 and estradiol less than 10 picograms per ml are considered to be abnormal. Hypercalciuria, calcium creatinine, your labs for thyroid, Cushing's, definitely want to suspect that if you have signs of Cushing's on exam. Hyperparathyroidism, your usual labs. For celiac disease, this is often missed. I had done a talk on celiac a few years ago, so keep that on your suspicion list, especially for type 1 diabetics, for autoimmune conditions. You will find many patients that were not diagnosed just because they didn't have the usual symptoms. They might not have the rashes or so, but they might say, well, I get bloated every time. I've always been bloated every time I eat bread or pastas, or just a lot of non-specific symptoms can go with celiac. So make sure you test for that, even with the slightest suspicion. Mastocytosis, hemochromatosis are kind of rare. Malabsorption disorders, so anything, gastrectomy, any GI, Crohn's disease or so, which are likely to cause malabsorption, entail definitely urine calcium, vitamin D, and even a serum calcium. So multiple myeloma, like I mentioned before, SPEP, and anemia might be evident on CBC. So now we have all this information. Who should we treat? So the criteria based on bone mineral density alone identifies very few men, less than 10%, whereas we know that 25% experience fracture after age 60. Like I mentioned before, a lot more men in the osteopenic range break their bones versus those in the osteoporotic range. So majority of men who fracture have T-scores that are better than -2.5. T-score only criteria ignores the other risk factors that they might have, which includes age, previous fractures, or comorbidities. And FRAX may help identify larger proportion of older men in whom therapy can be cost effective. But it still is not foolproof because it only considers the hip BMD and doesn't take into account other factors such as fall risk or so. So as a rule, again, with the Endocrine Society guidelines, we treat men with fragility, fractures of the hip, or clinical vertebral fractures, men with T-score of minus 2.5 or worse at spine, femoral neck, or total hip. And then there's further studies that might be needed to consider treatment for this in-between category between minus 1 to minus 2.5. Even though they might have a FRAX score of more than 3% for hip or 20% for major osteoporotic fractures, it's a lot of clinical judgment, but also evaluation for secondary causes and treating those first. Steroid use, and we'll go into details of that in just a minute. So the main three things are lifestyle measures, measurement of underlying conditions, and then men who need the non-hormonal pharmacotherapy. The lifestyle measures, recommendation of weight-bearing exercises for 30 to 40-minute sessions, 3 to 4 times a week, smoking cessation, and excessive alcohol intake. Now, excessive alcohol intake is defined as 3 units of alcohol, and that's 10 ml in UK, 10 grams in Australia. In US, it's defined as a small glass of wine or a shot of spirits, or I think it's half a pint of beer or so. So that intake should be avoided. And then maintenance of calcium intake, about 1,000 to 1,200 milligrams per day, mostly from dietary calcium if you can, but then supplements if needed, and vitamin D of 600 to 800 units, depending on the age. Treatment of underlying conditions. So hypogonadism, like I mentioned, was one big secondary cause of low BMD. Baseline testosterone levels less than 200 nanograms per DL increases the odds of having osteoporosis 3 times. In this particular study called the Dubbo epidemiology study, the risk of low trauma fracture was higher in men with baseline testosterone levels in the lowest quartile. And then, like I had mentioned before, estradiol levels less than 10 and testosterone levels less than 200. So are causes for fracture. So keeping them above those levels will prevent that. Treatment of men with testosterone levels in the normal reference range is not going to benefit. So treatment for individuals in whom the testosterone levels in different studies, in those studies were 200 to 300. They chose the lower cutoff just to be on the safer side. But anything less than 200 needs to be treated. More than that is probably not going to help. So for management of hypogonadal men with a high risk of fracture, those that we know have a high risk of fracture, in addition to testosterone, an agent with a proven anti-fracture efficacy should be added. Just testosterone may be used for those with a borderline risk for fracture if the testosterone levels are less than 200 and they have symptoms of hypogonadism. But if the symptoms are not better, then it's recommended that the testosterone therapy be stopped and you consider the bone drugs or the anti-resorptive or anabolic drugs. For men with a high-risk fracture with testosterone less than 200, but who lack the standard indication for testosterone therapy and have contraindications to approved osteoporosis pharmacological therapy, you could try the testosterone. Glucocorticoid use. FRAX estimates the 10-year probability of fracture for untreated patients between age 40 and 90 years using all these parameters, including glucocorticoid exposure. But it does not account for the dose and duration. So when the FRAX risk is calculated in a person who is on glucocorticoids equal to more than 7.5 milligrams per day of prednisolone, they suggest that the risk estimate be increased by 15% for major osteoporotic fracture and by 20% for hip fracture. So whatever number you get, go ahead and increase it by 15% for MOF and 20% for a hip fracture. Also, FRAX may underestimate the risk in glucocorticoid use as the spine BMD is affected more than the hip, and it doesn't take the spine BMD into account.
7.5 for over.
What's that?
7.5 over.
Right, and it's even, actually, they're pretty more comprehensive. Like you can see in the slide, it's actually even recommended for less than 50 years if they're taking more than 30 milligrams of prednisone, which a lot of COPD patients might be taking for more than a month. So they might be included in that too. So for men less than 50 who have a fragility fracture while receiving glucocorticoids, this is from up to date. That category, they do recommend pharmacological therapy. For those who do not have a fragility fracture, but you've seen on serial DEXAs that they are having a progressive decline of more than 4% per year, or a Z-score that's -3. Remember, the normal definition for low BMD in less than 50 is -2, but Z-score is -3 while receiving the glucocorticoids of 7.5 prednisone more than 3 months. Pharmacological therapy is recommended. For more than 50 years, who have osteoporosis, previous fragility fracture, or a T-score that's worse than -2.5. This is, I don't think I have the sign right here. Pharmacological therapy is recommended. For high-risk men more than 50 years who are initiating or are chronically treated with any dose of glucocorticoids and have a T-score between -1 and -2.5, they also recommend pharmacological therapy. So basically, in this steroid age group, we're kind of more likely to treat them, especially if the FRAX calculated risk scores are more than 3 or 20%. If they have a FRAX calculated absolute risk below the thresholds that they have mentioned, this is FRAX calculated corrected, I must mention. So if your FRAX calculated without correction is less than 3, then you have to make sure that you are adding it 20% or 15% for those HIP and MOF and calculating it accordingly. If the risk scores are less than what the thresholds are, if they're taking the prednisone for more than 3 months, they still recommend pharmacological therapy. These are kind of hard to remember sometimes, so you might just have to pull them up and look at them if you have a patient with the steroids on board. So what is the choice of therapy? In general, bisphosphonates, which is oral alendronate and risedronate, are the first line of therapy for prevention and treatment of glucocorticoid-induced osteoporosis. In hypogonadal men who are also on steroids, they want to do that along with testosterone therapy. And teriparatide is preferred with severe osteoporosis, especially T-scores which are worse than -3.5 or below, or in the absence of fracture, even in the absence of fracture, if they're worse than -3.5, or if they have -2.5 and below and a fragility fracture. It can also be used if they're unable to tolerate bisphosphonates or have a failure to bisphosphonate, which is fracture after 1 year. For those patients who receive teriparatide as initial treatment and who continue to remain at high risk, so after 2 years, you can't use the teriparatide anymore, and if they continue to be at a higher risk, you can add the bisphosphonate. And denosumab may be beneficial in some patients, but some of these newer agents have not been studied enough. So patients with androgen deprivation therapy, usually those are prostate cancer or so, the osteoporotic fractures occur in 20% of men, so a fifth of the men within 5 years of starting the ADT, and we should consider addition of an osteoclast inhibitor to reduce the risk. When the 10-year probability of hip fracture is more than 3% or 10-year MOF is more than 20%, osteoclast inhibitor should be added. But even in those patients who do not fit that criteria, it should still be considered. So that's what this last statement says, according to the American Society of Clinical Oncology. Yeah, pretty much. Pretty much. So of course, all these patients who have fragility fractures and fit the criteria, but then even those who don't fit, you should consider adding it. So it is recommended to reduce the risk of skeletal-related events. The treatment doses are different than the prevention doses. Here, the prevention of osteoporosis doses, your usual denosumab, 60 milligrams subcutaneously every 6 months. And then IV zoledronic acid is an alternative, but it has not been approved specifically for this ADT or androgen deprivation therapy patients. So this study from the New England Journal just kind of gives a good visual data on the mean percent BMD change per skeletal site with denosumab in men who were on the ADT with history of prostate cancer. So there was about a 6.7% increase excuse me, in the BMD at the lumbar spine, 4.8% in hip, 3.9 in the femoral neck, and 5 points. So across the board, there was an improvement seen at all sites, including the distal third of the radius, which is where the cortical bone loss occurs in androgen deprivation. They also looked at fracture endpoints and saw that the incidence of new vertebral fractures at 12, 24, and 36 months was lower in the treated group, the denosumab group. And the effects were seen pretty early on and continued through the therapy. So in gastrointestinal disorders, celiac disease, like I mentioned, is an important one. The osteoporosis is majorly due to the secondary, it's multifold. So one is the vitamin D deficiency, but because of the vitamin D deficiency, you could have secondary hyperparathyroidism, which could all be contributory. So in severely vitamin D deficient patients, of course, you definitely want to treat it. But also going on a strict gluten-free diet by itself can also result in significant improvement in bone mineral density. There's no particular recommendations of using any other pharmacological therapy in celiac disease, unless, of course, I would say you have a fragility fracture or so. In inflammatory bowel disease, there are multiple other causes of the osteoporosis, which includes inflammatory activity of the disease itself, steroid use, especially for Crohn's or so, hypogonadism, and other nutritional deficiencies, especially vitamin D. So lifestyle measures, basically lifestyle measures are important in all of these. But in gastrointestinal disorders in particular, you have to make sure that your calcium and vitamin D supplementation is actually enough to get your levels to normal, because of the malabsorptive nature of this condition, much higher doses might be required, and this should be assessed with serum and urinary calcium, vitamin D, and PTH levels. And calcium citrate is better tolerated than the carbonate, so that's preferred as a supplement. This kind of, again, is similar to what we read in the hypogonadal. If you have low testosterone levels with a secondary condition, you do need to replace the testosterone. For men more than 50 years with the inflammatory bowel disease and established osteoporosis, they should be treated with pharmacological therapy. It's the same for men and women. For more than 50 without established osteoporosis, you use the FRAX tool. And if you have men more than 50 who have a FRAX calculated risk below the usual cut points, but they're on steroids, then you need therapy. So anybody who has obvious osteoporosis, you need the therapy. If you have FRAX high risk categories, you need therapy. If their FRAX is not high risk, but they are on steroids, they need therapy as well. Again, oral bisphosphonates are the first choice. However, if GI intolerance to oral medications is present, you can use IV bisphosphonates, including ibandronate in this case, but mostly zoledronic acid. And teriparatide or denosumab can be used for failure of bisphosphonate. So who should get treated with the non-hormonal pharmacotherapy? Anybody with obvious fragility fracture and T-score less than -2.5. This is in eugonadal men. We already know in hypogonadal men, we need to do the testosterone and take the other criteria into account. But for men more than 50 with T-scores between -1 and -2.5, those at high risk for FRAX, they can also be included in the non-hormonal pharmacotherapy, and those with multiple other secondary risk factors, especially those who qualify by the glucocorticoid criteria, who are on GnRH agonists or have undergone organ transplantation, they can qualify even if they don't reach the FRAX thresholds. So this almost kind of is something that we have covered. But hypogonadal men will be on testosterone. For those who are on testosterone at a high risk for fracture, we add the pharmacological therapy, and this gives you kind of a comprehensive list of who all is at a higher risk. So high dose steroids, frequent falls, fragility fracture, BMD scores less than 3.5, and even less than -3 if they have other risk factors. And if the BMD is -2.5 and they have received testosterone therapy for 2 years and they continue to fracture or have poor scores, they should be treated. So bisphosphonate therapy, there were several trials that have shown that oral bisphosphonates reduce the risk of vertebral and non-vertebral fractures. In this meta-analysis, they looked at 6 trials and they all had a beneficial effect. If oral bisphosphonates are not tolerated, then you do use the zoledronic acid. It was interesting in this one study that the IV zoledronic acid was shown to have a significant fracture reduction when it was administered within 90 days of a hip fracture. So if you have a patient who's just had a hip replacement and is in need of osteoporotic therapy and therapy for osteoporosis, then I would probably choose IV zoledronic acid within 90 days.
Fracture or replacement?
Fracture.
So another second fracture.
No, to prevent further fracture. So if they come in saying that they just had a hip fracture that was treated.
Is it just another fracture or any major
fracture later? I think it is hip, but I'm not positive on that. So this graphical representation, this spiel on the right side talks about a whole lot of things, but we're really just looking at the or the lumbar spine, where results are shown for the bone mineral density improvement when these patients were on zoledronic acid in osteoporotic men. I really haven't talked much about the bone turnover markers, but in this particular study, they did show an improvement in bone turnover markers as well. They do recommend checking bone turnover markers at baseline and 3 to 6 months when you're starting therapy, but there is no particular cutoff points or standardization of using this data. So if you're starting anti-resorptive therapy, you want to see a 50% reduction in the bone resorption marker, which is usually the CTX. And if you're starting anabolic therapy, you usually see an increase in the first few months in the bone formation markers, which is the one that's usually checked as P1NP. But we probably talk about this later about what everybody's experience is, but I really don't think that I've found them very useful. So this is another graphical representation of the primary endpoint, which was 24 months of fracture risk reduction in patients who were on the IV zoledronic acid, and 12 months, which was the secondary endpoint. And you can see that there was a 67% reduction both at 2 years and 1 year after IV therapy in men, IV zoledronic therapy in men with osteoporosis. So those who cannot tolerate bisphosphonates or have difficulty with dosing requirements, anabolic therapy such as teriparatide or the osteoclastic inhibitor agent denosumab should be used. For men with severe osteoporosis and at least one fragility fracture, teriparatide can be used. Denosumab increases BMD in men with low bone mass, but other than the ADT patients, there was no fracture risk reduction shown in some of these studies. So it really did well with increasing the bone mass, but there was no fracture endpoint data that was studied other than the prostate cancer patients. And these newer agents, romosozumab and abaloparatide, are being evaluated. This was a percent change in the BMD on 20 micrograms and 40 micrograms of teriparatide. We used the 20 microgram dose because it had similar side effect profile to the placebo, whereas the 40 microgram has been shown to have higher side effect profile. And this is the lumbar spine BMD from baseline to 12 months. So can combination therapy be used? Bisphosphonates with teriparatide is not recommended. However, you could use bisphosphonates after you finish your 2 years of therapy. In both men and women, adding a bisphosphonate offers no additional benefit, and they think it might even impair the ability of PTH monotherapy to increase the spine and hip BMD. And there's some, I don't believe that this has been studied in men at all, but combination therapy with denosumab and teriparatide was shown to have increased BMD in women. So I guess, what's that? Yeah, I don't. Yeah, it was only in women. It was not done in men. So that's not recommended in men. So that combination therapy is not recommended until it's studied further. Okay, so let me see. We're close to almost 10 minutes to 5. Case 1. And I have almost 9 cases, so we'll breeze through these fast. But if there's something that you want to mention about while I'm flipping on these, please let me know. So 72-year-old white man with history of delayed puberty, Kallman syndrome, he's already diagnosed with it, came to me on topical testosterone therapy. He had a family history of osteoporosis in mother, risk factor, smoked a pack per day from age 18 to 43 years, and had lost about 1.5 inches in height. He did not have any fractures or renal calculi, and if needed, he really didn't want to be on any oral medicines. This was his T-score at the LS spine, minus 4.4. His hips looked bad as well, not quite as bad as the lumbar spine. And okay, here's his testosterone levels. It was well replaced at 610. So what would you want to do? Right. So in this particular patient, obviously all your lifestyle measures, he wasn't smoking anymore, but continuing the testosterone because of his hypogonadism, making sure the testosterone levels are at goal, and IV zoledronic acid was administered.
You could make a case of sodium oral side.
For this particular patient?
Yeah, because your
with the
score is so high.
Right.
Anabolic first.
Right. -3. It was worse than -3.5. I could have. Yes. That's very right. But personally, I've had so much trouble getting anabolic agents approved, and I have a case of that too. So, but yes, that's right.
He didn't want to do daily.
He didn't want oral medicines of any sort.
Or even daily injection.
He probably would not have. He was very particular. So this is an interesting case. A 19-year-old young man. He was actually the son of my kid's teacher. 6 feet 4.5 inches tall, with a BMI of 22.4, presented with history of repetitive tibial stress fractures from age 17 to 19. He also had a history of wrist fracture after snowboarding, and another wrist fracture at age 17, just doing one of his physical activities. He has a history of pectus excavatum, no dentition issues, renal calculi, celiac disease, or gluten intolerance. He did his sport activity 3 hours daily and drank about 40 ounces of juice daily. So, this was kind of a tricky one for me because he was a young lad, fairly healthy, pretty active. So snowboarding, wrist fracture, these are not fragility fractures, not at that age. This was probably a hard fall. But he did have this repetitive tibial stress fractures, which kept him away from his sport, and they wanted to do something about it. So, what's that? Yeah, he didn't look marfanoid or anything. He just had everything was, that was fine. And his dad was tall. I have another basketball player who's 6'10". So, but again, no marfanoid features or so. So I couldn't figure out why he had the pectus. I thought it was mostly because of his sudden increase in height, whether there was any that causes the. Yeah, he's on here, but let me breeze through these and then we can talk. So he didn't appear hypogonadal. He had good secondary sexual characters. So I have not included all that data, but the workup was positive for a high 24-hour urine calcium. So usually anything more than 3 to 4 milligrams per kilo of calcium in the urine, if you go by weight-based, is considered to be hypercalciuria. So he did have significant urine calcium. Diagnosed him as idiopathic hypercalciuria and started him on thiazide. He improved his diet. He drank more milk, just dietary calcium, but no other sugary foods, and just basically continued to do his usual activity. He had halted his sport for some time, but post-treatment, which was, I don't have his post-treatment urine calcium, it came down to 200 something. He didn't have fractures for more than a year. So as you can see in this particular patient, I didn't even do a DEXA scan because I'd already identified a secondary risk factor at least, and probably getting the DEXA would not have made any difference to my management plan if he hadn't improved already. Oh, here it is. 24-hour urine calcium was improved at 291. Okay. So this is a 24-year-old white man with cerebral palsy, primary hypothyroidism, history of epilepsy on valproate therapy, was referred for low BMD. He had been maintained on calcium, vitamin D twice daily, drank milk, ate a lot of yogurt, he walked some, though, you know, he didn't have a normal gait, but he did do some weight-bearing exercise. No fractures, dental issues, not on any steroids. His scores were as below. He did have a Z-score of minus 3.3. All of his labs were normal, and we couldn't do a 24-hour urine for hypercalciuria because of incontinence. He's not immobilized, but he has some gait issues just with the cerebral palsy. So we just increased his weight-bearing exercises and continued calcium, vitamin D, and cautioned about fall. And I'll just plan on monitoring his DEXA as a follow-up and see how he does. Yeah. And then, he probably had, I'm not sure, I don't think I have his pubertal age, but I don't know if he had delayed puberty. Okay, what's the matter with this? Okay, so 84-year-old white man with a history of right hip fracture, already on denosumab therapy, surgical hypogonadism due to unilateral testicular orchiectomy for a germ cell tumor, primary hypothyroidism, family history of osteoporosis in father and paternal grandmother, which I was impressed that it was diagnosed, in both back maybe many years ago. Smoking in the early 20s, had a loss of height of 3 inches. He had been on epidural steroids, PPI, and also had type 2 diabetes, though it was well controlled. He had been on adequate calcium and vitamin D. His weight was 64 kilos. His DEXA showed a T-score of minus 3, and a distal third of the radius T-score was very low at minus 5.4. His vitamin D was low at 18. As a result, his parathyroid was high. Levels were high, 51.9. He had borderline elevated 24-hour urine calcium levels. Celiac screen was negative, SPEP was negative, total testosterone was 169. So this was a tricky one again. Would denosumab be considered as failure? He had the fracture when he had already been on therapy. So I had initially stopped it and alendronate was started. At that time, we were trying to get him on anabolic therapy, but it was not approved and he couldn't afford it. So since Prolia was stopped, I had to put him on something else. Thiazide was started for hypercalciuria, vitamin D was replenished, and then his testosterone was a little bit low. And the question was, could I put him on testosterone therapy with this past history that he had? He had been stable. He had never had any prostate issues or androgen deprivation done for any of this. So I think this was one that I discussed in detail with Dr. Watts, who is like the guru, and I believe I talked with Dr. Winters as well about this patient. So his anabolic therapy was finally approved. So we stopped alendronate because you can't be on both. But then, for some reason, after discussion, we had started denosumab back on him after talking with Dr. Watts. And then, more importantly, I also got him on testosterone therapy, very low dose, and he has done very well. So, since it was not a testosterone-driven tumor and he had been stable for 15 years, the decision to start low-dose testosterone was done. After therapy for 2 years with the anabolic regimen, his left hip BMD had increased by 8%. And his denosumab really was started almost towards the end of his anabolic therapy, so not a whole lot of overlap. I had another patient, a 42-year-old white man with Kallman syndrome, who was undiagnosed when he presented, but did have a history of thyroid cancer. He presented with thoracic vertebral compression fractures. Every single one of his T1 to T5, he had a vertebral compression fracture. Maybe not 20% loss of height, but he did have it after an MVA, and also a hand fracture after hitting it on a hard object. He also had a history of infertility. He was obviously hypogonadal with gynecomastia, no body hair, very obese, seemed to have no muscle mass. His DEXA scan showed Z-scores in the normal range. His testosterone was less than 2, never been treated. And he was started on intramuscular testosterone. Post-therapy, his numbers were much better, improved body hair, muscle mass. He had a repeat imaging done for his vertebral spine, which showed no fractures since his earlier fracture. Okay. So this 46-year-old Kenyan African man with a BMI of 27, again, an avid athlete, taekwondo, presented on therapy after sustaining a rib fracture after a low-impact rear-ending MVA. So he wasn't on the alendronate when he had the MVA, but I think his primary care doctor started him on it when he had that rib fracture after this low impact, which again is kind of a difficult to define thing, but after rear-ending MVA. He had a history of inhaled and oral steroids for asthma, intra-articular steroids for shoulder impingement, smoked many years, a 44-year history, and also had alcohol abuse. His Z-scores at the lumbar spine showed -4 reading. His hips looked fine. His lats, for the most part, looked fine. So he was, again, maintained on calcium, vitamin D. I chose to continue him on the alendronate therapy because of his poor Z-scores, and then we suspended taekwondo for, I think it's been 3 years now. So follow-up DEXA showed improved BMD at the spine. Overall, the Z-score is still low at -3.7, but no new fractures. I guess the question is, how long should I continue him on his alendronate? And one thought is, he's been on it for 3 years. Should I just go ahead and stop him, give him a drug holiday, and see how he does? I think one of the limitations that I thought was how much of his being a Kenyan African person would have factored into his scoring, because they're usually very thin and wiry individuals, which he is. I mean, even though his BMI now of 27, he's mostly abdominal. But should I rely on this just as much with the Z-scores? He had a rib fracture. Now, some literature defines rib fracture as also a fragility fracture, but then there's no concrete definition.
They call them insufficiency fracture.
Right. There is no particular guidelines on rib fracture, but the Z-score is definitely concerning. But is it true? Is it a true indication of his bone health?
So if the Z is so severely low, but his hip is like close to normal, that makes you wonder.
That's the lumbar spine, the Z-score.
Yeah.
Yeah.
The hip,
Yeah, the hip is fine.
You shouldn't see, unless he's severe hypogonadism or chronic steroids, you shouldn't see such a big difference. So it may be worthwhile looking at it again. I'll use a different DEXA scanner.
Yeah, or just use the Prax calculator, and see what needs to be done.
The bone markers might help you, where it doesn't add up.
Right.
You may be able to get a couple of
Yeah.
different ones.
And he's been on it for 3 years, so we're definitely going to stop it now and reassess because you can't use fracs on therapy. So then this is a 70-year-old white man with vertebral compression fractures, already status post kyphoplasty, loss of 3 inches in height, had a left wrist fracture. I wouldn't call that fragility fracture because he fell in an empty swimming pool, and ankle fracture when he slipped on ice. He does have a history of frequent renal calculi, no smoking, alcohol, steroids, meds that would cause bone loss, but he had a history of prostate cancer that needed surgery, but he was not on androgen deprivation therapy. He did have a history of leukemia as a child. That's his lumbar spine T-score. Vitamin D was low, 24-hour urine calcium was a little bit high, testosterone SPEP was normal. So he was treated with thiazide, and I chose to put him on denosumab, even though he's not completely categorized as androgen deprivation therapy, but with his prostate cancer history, I just chose to put him on that. A 31-year-old white man with a history of type 1, diagnosed at age 4. Risk factor itself, celiac disease, another risk factor. Smoking history of 8 years, risk factor. No hypogonadism, steroids, or renal calculi. Had a left foot stress fracture. That's not considered a fragility fracture. But did end up doing a bone density, and his right forearm Z-score was minus 2.5, and so was his hip score. His vitamin D levels were low. Every other test was okay. So maintaining him on a strict gluten-free diet, making sure the vitamin D is more than 30, which is what the recommendation is, by the way. All vitamin D levels need to be treated to more than 30, and maintaining calcium in his diet was recommended. So a few take-home points. Osteoporosis in men is underdiagnosed, undertreated. Mortality is higher in men than women from hip fractures. There's more men in the osteopenic range than the osteoporotic range, which means that DEXA may not by itself be enough. DEXA for screening may not be covered by insurance, so even if you want to, you might have some hurdles. We really need to recognize the existence of the silent condition and consider screening with other cheaper alternatives, diagnose and treat those at risk for morbidity and mortality. So we learned the breaking trends. How can we break the current trends? And I don't think there's any particular guideline. We all know that there's already so much to do in the clinical practice. How many of us would go and do a FRAX or FRC on every single man that's more than 50 years of age, or definitely more than 70 years of age? So could there be an electronic screening tool where, just like how the women get reminders, your mammograms due, your this is due, could there be a way that men can get, or do your fracture risk assessment? This is the tool, put your numbers in, and if there's no BMD needed, they could very well do it themselves. Other option is to just be able to do an automated, maybe there's an algorithm in EMRs that they could automatically churn up a number and put it on your patient banner that says fracture risk high, and then could we screen those? So these are just some of my suggestions. I'd be happy to hear what your suggestions are and answer questions. Thank you.
What is the mortality related? Higher mortality.
The higher mortality? I don't know. Is it just because they are immobilized, and does it cause, other issues secondary to it? I don't think that any of the literature that I read actually gave me the cause for the mortality. But that was just epidemiological.
Because it says that after hip fracture, men are more likely to die, older men than age compared women.
Right, right. But he's asking the reason behind it.
Why are they dying more? Is it because of coronary disease or something else? Because this is the thing that has been, like when you give them anti-resorptive therapy, because these are the most studied, there's actually a reduction in mortality. In the
after therapy.
If you take these large studies and look at mortality rates, you will find that there's in fact, Dalzikian keeps saying that the mortality difference that you get in the osteoporosis studies is more than the statin studies. Now, although nobody markets alendronate as something that that is part of the thing that they have.
Yeah.
Hi,
So-
Swapna. How you doing?
Good, how are you?
Ready for one more question?
Yes, I
So
am.
I think your case number 2 underscores the importance of thinness when one takes a history, and especially in young men. You know, the idea that thin young women, because of diet and exercise issues for them, increases their risk for osteoporosis, is also true for men. And the men can be hypogonadal. So I think you should think about the BMI in a younger person. And of course, I would measure SHBG, because in thinness, the SHBG is going to go up, and your criteria for testosterone are going to miss the men whose total testosterone is normalized because their SHBG is high. So I'd like to see SHBG added to the criteria for all of the men for testing. And I'd like to think that thinness should be considered as one of the risk factors.
True, but he was not overtly thin. As you can see, the BMI was just about in the normal range. So,
no, but that's low enough. That's low
but
enough.
also, I think he just had improved his bone.
That's low enough. That BMI is low enough to cause hypogonadism.
But this particular gentleman really didn't have any hypogonadal presentation or so.
Well, but this is what I'm arguing. What I'm arguing is that people who are thin like this, one should check their testosterone and SHBG, because thinness to this level was frequently associated with low testosterone, and that high SHBG is going to mask the fact that a testosterone level of 300 might be very low, because the SHBG might be 60 or 70 nanomolar. That's what I'm arguing. I know it's not in the literature.
Right,
but
and
it's
it's
just
also
my
going
opinion.
to be difficult to use those SHBG numbers. So you need to have a cutoff and some kind of data that shows certain SHBG levels. I guess that probably could be something, but I guess utilizing what we have right now itself is a challenge. So adding more might be even so.
Well,
but I agree with you that thinness is a risk factor. It has been mentioned in all the risk factor lists. But for a young man like him, with a BMI of 22.4, which I would consider pretty normal. Now, if he's 18 on his BMI or so, again, I don't know that there's any particular cutoff for calling somebody thin. This should be a normal BMI.
Well, I'm just saying that men with this type of BMI can have a very low testosterone. It's been reported.
Okay.
And it's especially true when they're very involved with dieting, and they're trying to keep their weight down by dieting, and they get very involved in exercise programs. You know, a scenario that we know very commonly in ladies.
Right. You're right.
But it's underappreciated in men.
Okay. I'll certainly keep that in mind. His urine calcium, though, was pretty interesting, and the fact that he improved after that was helpful. Thank you, Dr. Winners.
Absolutely.
So have they looked at, one of the problems with men in general is in convincing them to get screened for asymptomatic disease or take medication for asymptomatic.
That's true.
So is there a comparison thing that can be come across?
No, because I don't think any of these really took the patient decisions into account here. Overall, yes, wanting to get treated and then compliance with treatment have been some of the factors that have actually caused some of the trials to not show the benefit because patients just didn't take what they were supposed to. So I do think there's a lot of public misinformation that osteoporosis is predominantly a woman's disease and that they really don't need to be screened. So I don't think any 70-year-old man thinks, oh, I didn't get my DEXA. So whereas a 50-year-old or 60-year-old woman, like, oh, I should probably be getting my DEXA soon. So I think that lack of information is one of the major reasons. Also, there weren't enough studies to know that if you had osteoporosis, which therapies would help. So if there was not going to be any therapy, then there was no point in screening all these individuals. But all the recent trials, and there definitely has been a benefit to fracture reduction. So that's important, that now that we know that therapies work, maybe it's time to go ahead and find the pool of patients that need therapy. And also diagnosing secondary causes, which is a big chunk of the men. Where do I get to the chat window? Am I missing the chat window?
Will you reimburse if you do just fracts without bone density?
Do you do it?
If you do fracts without bone density and you order reclass, so
Would you get reimbursed?
I mean, will reclass be approved, or do they
I know in England it would be,
Yeah.
but in US, I don't think anybody does that. Like, I don't think anybody has dared to do a frax and treat them. I mean, we are kind of very prone to ordering tests as a country. So because England relies so much on their public resources, I think they have more.
Can I stop sharing?
Yeah.
Yeah.
Okay,
Maybe
stop
that's what
sharing.
it is.
Yeah.
Thanks, Malika.
Here.
Okay, we have.
Go to chat.
Let's see.
There we go.
Oh.
Oh, okay. So, thank you, Mr. Kotwal. So, smoking and excessive alcohol consumption. Smoking by itself, they don't have very strong correlation with fracture and osteoporosis, but it has been, it has an overall benefit on the, and just smoking cessation in general is good as a lifestyle prevention. So it's that's what is recommended, but there is not a whole lot of studies that show, and I'll actually refer to this for that in particular, that it's directly correlated. Now, alcohol can cause hypogonadism, frailty, falls, and that could be other contributory factors, and that's how it can make osteoporosis worse. So let me look at this in particular, because I know that they had a specific but I can tell you that there's not a strong correlation of smoking and osteoporosis directly. And I can.
But that is included in your practice.
It is, yeah. Okay, the mechanisms by which smoking may increase fracture risk have not been determined. And then the benefits of stopping smoking on hip fracture was not apparent until after 10 years. And the offset of effects in men is not known. In women, it might improve after 10 years. There is a correlation in the sense that the relative hazard is about 1.5% for all fractures for somebody who smokes. There's an association, but not causal. So what they wanted to say was they placed a higher value on preventing smoking-related complications because data showing smoking cessation reduces fracture risk is limited. So really there is not a whole lot that we can do, that we can say that stopping the smoking is going to help with the fracture risk. So also, besides genetic abnormalities in hormone production, what are other genetic predisposing factors? Family history, and I don't think that that I have read specifically about how genetic factors or family history can affect the microarchitectural bone. We just simply don't have enough information on the structural quality of the bone that might be present from your genetic predisposition. There are no particular genes that I read that I could tell you that could put you at a higher risk of having osteoporosis. Does that answer your question, Mr. Kotwal?
Thanks. Yeah, that does answer my question.
Okay, thank you. Anybody else with questions? And I'm so sorry I went so far over.
No, that's fine.
I didn't even realize it's 5:22, which means my parking meter has expired. So,
Okay.
all right. Thank you all.
You have a lot of energy upstairs.